Yeah, so our title is Specialist Midwife for Perinatal Mental Health, which obviously, you know yourself, perinatal covers a huge spectrum of the antenatal and postnatal journey. So it's a brand new role to our health board, and it's a fairly new role in general. I think the longest serving specialist midwife in Scotland is about 10 years, but there is only 6 of us in total in the country, and everybody works a little bit differently. The role came about, we were appointed in December, believe it or not, and didn't start until just the very end of March, just with the way things go. And it's all just come on the back of the Delivering Effective Services document, and then the funding that was associated with that. So with that in mind, we've done lots of networking. So the very start of our role was just, right, let's see what's out there. The main part of our role is to support the midwives initially. Obviously, continuity of care is such an important thing, but we all came from a community background where we were very aware that our own knowledge of perinatal mental health in terms of formal training was negligible. So we wanted to do some networking just so that we could support our midwives to and update their knowledge in order to support the women so that they knew then what services were out there. Our main interest at the moment from a midwifery point of view is like these early interventions in terms of anxiety related to pregnancy and or birth, whether that's a previous birth, birth trauma, and then actually, so that's what initially instigated us reaching out to Chris, just to see what was available from a partner's point of view, because obviously we're acutely aware of the role of the partner and supporting the women in the family unit, and really trying to get that language change from, we went from individualised care to women-centred care to person-centred care. Like everybody's always had language on their radar, and then really we started thinking we actually need to stop talking about women-centred care, we need to talk about family-centred care, whatever that family unit looks like, whether that's a woman on her own, 2 women, a woman and a man, anything. So it really just encompasses like thinking as the family unit. My background, I was part of a Best Start team. So I was part of the pilot for Best Start in Clyde, pre-COVID. So it was obviously COVID that put a little bit of the dampener on how we were working with that. And I would do all of my antenatal care from home. We would meet our women from booking. I would know siblings, fathers, mums, grannies, pets' names. And that really, it's kind of giving you that passion for, yeah, this, we need to know everybody and they need to know us, just to improve outcomes for everybody. One of the things that really interested me from chatting with Chris is how traumatized men can be at like birth. And obviously it depends on the midwife and each individual practitioner. I've always been acutely aware during my intrapartum care about, this isn't my experience, this is your experience as a family. And I would always give men jobs to do, because ultimately they're sitting watching their most precious commodity bring in their new most precious commodity, and they're feeling pretty helpless. And then if things don't go to plan, it's our bread and butter. We see it all the time. But what we've heard from just chatting with yourselves and other resources is that men immediately go to, but that was a life or death situation. And to us, it's probably not been a life or death situation, but to them and their perception of it, and that's what their takeaway from it is. So Chris had probably mentioned that one of the things I really wanted to do is just try and address that point of when things shift in the birthing room to, okay, we're going to a more urgent or emergency situation, and just really what support is there at that point to then hopefully prevent a deterioration in men's mental health going forward, because I'm aware that they're very forgotten about, and just try and incorporate that into the midwifery role as much as possible. So I'd said to Chris, and I'll confess I've not done it yet, but it's one of the things that I keep putting to my next week's to-do list. I'm thinking from the kind of emergent situation of leaving your birthing room, getting to theatre, and where there's a daddy sitting outside that room in the daddy's chair, where you're just said, you get into scrubs and you sit there and we'll be with you shortly. And then that 5-10 minutes of their life, they're probably catastrophizing. They haven't got a clue what's going on in there and what they're going into. So that was where my idea of let's get a poster, because we're never going to be able to, well, we're not for, I think in my lifetime, going to have a member of staff with them. So I wanted to put a piece of literature on the wall and to give them something to do while they're waiting. I wanted to go down the lines of having even individualised to separate units. I wanted a picture of the theatre room on that and say, this is what you're going to come into. These are all the people that are going to be here. And while you're sitting out here reading this, this is what we are doing. It's difficult to do it because you've got to be quite general, because obviously there are situations where it's not going to plan and he's not getting in that room. I'm actually going to labour ward after this with a lady, and I thought, if theatre's empty, I'm going to take a picture of it while I'm in there. I would like to think that as a midwife, I always kind of had like an ear to the ground with partners, and not blowing my own trumpet or anything, but and I would hope that most of my colleagues are the same, but I'm very aware that they're not. So yeah, it's really just trying to incorporate that into education as much as we can, like just planting little seeds. So we're doing, like, in terms of referrals, you're doing like 30-minute buzz sessions on these are where you can refer women to, and then we're just sticking a slide in at the end, like, don't forget the dads or the partners, just to start getting it, because I'm also aware that we've got a very, as you say, understaffed health system of staff who are completely fatigued. And then if we go in gun-ho and say, right, you need to start doing this now as well, you're going to get massive resistance and you're just going to annoy them in the nicest possible way. So it's just softly, and let's just start to weave it in, and it's that changing the language and then changing the culture. A lot of what we are finding is, are the midwives not asking, say, that, like, the mental health questions, are they not asking because they don't know either the background of it, or they're frightened of the responses because they don't feel equipped with where to signpost, where to refer. So then doing a little bit of education around, like, the research behind having a supportive partner, a well supportive partner, to then support a woman, to then support an infant, and it's better outcomes for everybody, just to try and incorporate that into their education, just so that they know why we're asking them to do it. It's not just a case of, you need to do this. We're going to hopefully start to get into the universities as well, so that you're getting them from day dot, so that this is just ingrained into their practice. And the midwifery workforce is so young now and junior anyway, because of the curbing of the student numbers in the past kind of 10 years, and then the retirement. So it's a young workforce, and they're actually really receptive. Obviously they don't come with the wealth of clinical skills, but they're receptive to change, which is good. So it's just trying to weave that into, and always keep it in the back of your mind, like, right, where can we incorporate the dads?